We're gonna start now. So the how we made this whole lecture is that it's gonna be a rapid fire thing. Everybody, me, Jesse, and Alaa are gonna do 15 minutes on a topic, and we're gonna present the rationale behind the things that we do, and then at the end of it all, I think Jasmine has some questions as well. So the topic that I chose was prone positioning in ARDS, and down. Okay. So we all know we recently had a lecture on ARDS. In 1967, Dr. Ashma and colleagues basically defined ARDS as the syndrome with tachypnea, hypoxia, and reduced compliance of the lung. And now we have methods to help with oxygenation. With the basis of this whole treatment approach to ARDS is low tidal volume ventilation, and as the higher the PF ratio gets worse, we have the higher PEEP that we use, and then we have these non-vent strategies that work in conjunction with the ventilator to help our patients with severe ARDS. I'm going to choose prone positioning, and I would start off by explaining the physiology behind it and then the studies that involved prone positioning. So I actually want to just briefly talk about understanding how severe ARDS. So this was actually called the lung Sayf study. This was an observational study, and it was a really big study in 50 countries and 459 ICUs, and they looked at the effects of acute respiratory failure in the patients in ICU. And what they saw was at the period prevalence of severe ARDS in these patients was 23%, and the mortality in that subgroup of severe ARDS patients was almost 46%. So really high mortality in a patient with severe ARDS. And the thing that was interesting was that this the box on the left shows the non-vent strategies that we have, and only 16% of the severe ARDS patients were offered prone positioning. Now, is that because we think there's not enough evidence, or the physiology? So that's why we brought it up to talk about how prone positioning works and what evidence we have. So prone positioning is being there since the 1970s. Brian and colleagues proposed prone positioning, theorizing that it would reduce the pleural pressures, the ventral to dorsal pleural pressures, and would improve gas exchange. And there have been case series and studies that actually show that prone positioning does improve oxygenation in patients with ARDS, and even increases the PF ratio up to 30 millimeters of mercury. So we have evidence with physiology that prone positioning does help oxygenation. This is from the work of Dr. Gattinoni, and this is a simplified or maybe an oversimplified version of how this whole thing works. So if you follow with me, it's just the so we have a section here, this patient supine here, prone. This basically tells you the anatomy of a lung segment, the conical shape, and these are alveolar units. And as you can see that isolated lung basically has more alveolar units in the dorsal part of the lung than the ventral. And when we have patients supine, the dorsal lung units are not involved in gas exchange much. When we have them proned, they are more well ventilated and involved in gas exchange. The second column here actually now involves the chest wall with the isolated lung, and it shows how when the patient is in the dorsal position, it actually augments the gravity and helps inflation of the dorsal segments of the lung. So as we involve more lung units, our gas exchange does get better. What about pulmonary perfusion? So this is from a study done on sheeps, and basically how this study went about was really interesting. They did, if you see on the the x-axis shows the perfusion along the 8 coronal sections of a lung, and each section, the red is the shunt fraction that you see. So on a supine patient, as you go dorsally, the shunt fraction actually gets worse, because obviously there's less lung involved in gas exchange, and it works as basically dead space, and then there's there's more shunting in that area. When you have them prone, it doesn't affect the lung perfusion per se if you look at the graph, but it does significantly reduce the shunt fraction in the lung. So that was a study done on sheep, and the most dorsal segment on a supine patient shows almost 91% of the blood flow being shunt fraction. So prone positioning and extrapulmonary organs. Now, there was this article that actually talked about the beneficial hemodynamic effects of prone positioning, and this is only in patients who are actually preload responsive, and it makes physiological sense. When you prone someone, their right atrium is more ventral, so all the blood return is aided by gravity into the right atrium and then to the right heart, which helps your preload, and only in patients who are preload responsive, that's going to help your cardiac output afterwards. Not in patients who are not preload responsive. The other things, it can lead to, with patients who have high intra-abdominal pressures, it can actually worsen it when you prone them. So they've always recommended that you should have continuous abdominal pressure monitoring if you have a patient with high abdominal pressures. Now, finally coming to the studies in my last 7 minutes that I have, these are the 5 studies that actually have been done on prone positioning. Now, we can start from the top row here. I'll sum it up for you guys. Basically, time-wise, 2001, 2004, 6, 9, and 2013, which was the placebo trial. So none of the earlier studies show any mortality difference, but 2013, the placebo trial actually showed significant mortality, 28-day and 90-day mortality improvement, and also vent-free days. A lot of people criticize this study, but I think the study got things right which the other studies didn't. I'll highlight them as we go along. The thing was, obviously, it was after 2012, so we had a clear definition of ARDS, not the acute lung injury or the ARDS patient. So this study incorporated less severe patients. This was pretty clear-cut. The PF ratio less than 150, the people were included in this study. They consistently did not have, if you go to the bottom, they didn't have a lot of crossover between the groups that were prone or supine. They had a pretty strict criteria that a patient would not be prone, and this would be a last resort for the control group. The other things that they got right, which is a big thing, is the tidal volume. So if you look at the other studies, 10, 8, 8, and then it stuck to the 6 cc's per kg or less, that actually has been shown to improve mortality. The patients were paralyzed and paralyzed early, and the control group almost had an 87% of patients who were 87% paralyzed in the control, and then 91 in the intervention group. And then they also figured out the time from the earlier studies. They actually, everyone was prone for more than 16 hours at least. So how the study went about was, once they actually knew that the patient was deemed to be included in the studies, they gave a time frame of 12 to 24 hours to stabilize them, and once they were in a computer designated which group they'd go to, once they were assigned that group, in the next hour or 2 hours they were actually assigned. So really quick assignment. They stuck to the 6 cc's per kg. They paralyzed them early, and this was the placebo trial was done in France, 26 centers in France and 1 in Spain, and they had a lot of experience with doing this. So they had almost 5 years under their belt of doing these prone ventilation, and they did not report a lot of adverse effects from the proning, while the 2009 study actually did. But I think there was just a difference in managing and how comfortable they were managing prone patients. So summing it all up, I think with the studies and the evidence that we have, who should be prone? The subset of people who are moderate to severe, so the study took a PF ratio of less than 150 should be prone. It should be done early. It should be done with low tidal volume and with neuromuscular blockade. And this is a meta-analysis that showed that patients who had a lower tidal volume and were ventilation and were prone actually did better. And the Cochrane review, this came out in 2015, said that although there was a lot of heterogeneity between the studies, that had one group of participants with more severe lung damage appeared to have reduced mortality with proning. So prone patients, a subset of severe ARDS, prone early, paralyze them with a low tidal volume ventilation. It does require some personnel use. It's going to require 3 to 5 people. And this is the exact same thing that they did in the studies. The supplemental literature with the study actually tells you and goes through the whole procedure, how they had checklists before they did this. One person would be actually designated for the ET tube and central lines. You pre-oxygenate them, you do it on an empty stomach, you suction the secretions, and then you remove leads, prone them, and put them on the back. How long should patients be prone for? Now the studies from the placebo trial, we know at least 16 hours a day of proning. And in the placebo trial, what they did was, when would they stop proning a patient? When they achieved a set goal, which was a PF ratio more than 150, 4 hours after flipping them back on their backs with a PEEP less than 10 and an FiO2 of less than 60%. The optimal duration, or how long you keep proning them for, it's really unclear still. But we know the duration, and we have set cutoffs to when to stop proning. Who not to prone? Patients with facial or neck trauma or spinal instability, recent sternotomies, high intracranial pressures or massive hemoptysis, or who would require CPR. Potential complications which are reported: increased secretions when you prone them, ET tube migration or kinking, vascular catheter issues, residuals being high, and facial ulcers. So that's kind of my 15 minutes on proning. We can put questions at the end. And what it? Keep going. No clapping.
All right. I'm gonna try go through steroids with ARDS. Which one left?
Down.
Oh, okay. First of all, when I start to prepare for this, I looked into clinicaltrials.gov to see if there is any ongoing recruiting or actively going studies, and there was nothing when I put steroids versus ARDS. I was more heartened when I saw the American Thoracic Society document that came up in March 2017. Although it mentioned that it's talking about the mechanical ventilation in patients with ARDS, it mentioned most of the rescue therapies at the bottom, at the end of the document, including nitric oxide, including fluid management, paralysis. So I'm not sure if they consider steroids in ARDS as something not related to mechanical ventilation, although most of the secondary outcomes in the studies that I'll show talked about free vent time and free ICU time. So when I talked to Dr. DiGiovanni about this, he said, okay, they are talking about mechanical ventilation, that's why steroids are not there. I think they intentionally did not put it there because maybe of the weak evidence of steroids, but it's something to ask and discuss with everybody here. I'm gonna go quickly about the pathophysiology of steroids in ARDS, and then talk about the clinical studies, whether they were trials or retrospective studies that were done since the 70s up till now, but I'm gonna mainly concentrate on the use of moderate dose, prolonged course of steroids in the late phase of ARDS. And then we'll talk about a conclusion on whether or not we can individualize therapy or who might be the subgroup of patients that might benefit from steroids. So the story behind using steroids in acute lung injury goes back to 1967 when Dr. Asbagh mentioned in a paper that he noticed improvement in viral pneumonia and fat emboli patients when they use steroids. And this is where the idea of steroids being used in acute lung injury developed. As we all know from clinical studies, now we know that ARDS might be stratified into 3 phases. Of course, there are heterogeneities, and there are, now we're talking more about type 1 and type 2 ARDS, but the 3 stages, if I can simplify them, would be the exudative stage, which is the diffuse alveolar damage stage in the first 7 days, fibroproliferative stage, which happens after the 7th day, up to 2 weeks or 3 weeks, and then the fibrotic stage, which is the end stage of the lung injury in ARDS. Our mechanisms of defense in the body whenever the lung gets hit by whatever reason, pulmonary versus non-pulmonary, to cause ARDS are mainly dependent on the endogenous steroids and on our cytokines. And studies showed, including biopsies from patients with ARDS, that there is dysregulation of these defense mechanisms, including deficiency in our endogenous steroids, and this supports more the use of steroids in ARDS. And the effects of steroids in that specific fibroproliferative phase goes through many aspects, from the vascular permeability to the healing, and even to some cardiac contractility improvement. So as I mentioned, I'm going to discuss mainly the late ARDS. I'll just throw these 2 slides quick. These are some of the studies that were done for prevention of ARDS. It actually, if you can see here, it used a very high dose of steroids for a short period of time. So 30 milligrams per kilo, almost in all the studies, for 24 hours. And the outcome definitely was not promising. In early ARDS, there are these 3 major studies that whenever you read in any paper, they will mention them. While the first study was done and showed actually stopped early because of futility by Bernard et al. Ended up in 1985. The second study was interesting that they did not mean to study steroids in ARDS. Actually, they were studying fludrocortisone with hydrocortisone in relative adrenal insufficiency patients, and a subgroup analysis after the end of the study showed improvement in the outcome of ARDS patients who were non-responders to the concentropin test, meaning they did not have adrenal insufficiency. They ran them and found that their outcome was better when they used steroids from ARDS standpoint. The last study I'm not going to go through now, but and I'll tell you why. The clinical trials for late ARDS, the main 2 trials that happened are one by Midori, and this is where we have the Midori protocol, and the NIH took the Midori protocol, twisted it, and did another multi-center clinical trial that I'll go extensively through all of them. When I reviewed all this, I noticed how things started. Started with big dose of steroids for short time, prevention versus use in early ARDS, and then we did find no good benefit, so we started thinking of a moderate dose on a prolonged scale, and to be used in the late ARDS when pathophysiology started showing us more about the fibroproliferative phase. And this is the concept why Midori ran their study. It was actually I'm gonna skip this one, and so it was a single center, 3 hospitals in Memphis, and they recruited 24 patients out of 33 eligible. They had a relatively acceptable criteria even by us now for ARDS, and this was maybe 15 years ago. Their protocol was, I mentioned it, I highlighted it here. So 2 milligrams per kilo as a loading dose, followed by 2 milligrams per kilo per day for 14 days, and then tapered down over another 18 days, total of 32 days. And I'll show the difference between this protocol and what the NIH did. The Midori study also had a crossover, so if the patient on each arm of the study is not doing well, they will flip them to the other part of the study. And this is when they found that the mortality rate in the placebo group was very high compared to the steroid group, so they stopped the study. And out of 24 patients, they had actually a randomization of 2-to-1, so they ended up with 16 patients on steroids, 8 patients in the placebo, and they reported that the survival in the ICU was significant. None of the steroid patients died. Keep these results, and then we'll talk about what happened here. So here, this was a multi-center study that there were like 3,000, almost 3,000, more than 3,000 patients recruited, and then they had a strict exclusion criteria, and then they ended up with 180 patients. They used a tapering dose of steroid that I'll show you later on, but they found, interestingly, that there was a significant evidence of 3 days of the vent, 3 days out of the ICU, but there was no change in mortality on the long term. They had the mortality in 60 and 180 days, and I'll show you a slide where it showed no difference in mortality. They even found that the mortality in patients who were recruited after day 13, from 14 and above, had a worse mortality in the steroid group. This is a really important slide from that study. It shows how, so it has four arms: the prednisone placebo, alive, and breathing with or without assistance. All patients at the end, 60 to 180 days, ended up having the same outcome. And out of each arm, we have like 28 patients in the placebo group that died versus 29 in the methylprednisolone. 58 on the placebo group were relieved of the vent, 57 in the methylprednisolone. So there is no statistical difference in the arms, telling us that there was no difference. But what did we get from that study? We got that patients who were randomized after day 13 did worse outcome. Patients who had higher titers of procollagen 3, and I'll go through what is that if I have time, had better outcome. And this is an indicative of the fibroproliferative phase of ARDS. And there are many basic science research studies that were done on this marker, which can be measured through the alveolar and the serum. But the alveolar marker is more accurate depending on a recent study in 2015. Regarding side effects, having our transplant team here who does not like steroids. Infection-wise, the placebo group had 30 serious infections versus 25 in the methylprednisolone. Neuropathy, 2 in the placebo versus 9 in the steroid group. And I did try to make this table to differentiate between the two studies, and the points I want to mention are the time of enrollment in the Midori study is 7 to 21 days versus 7 to 28 days in the NIH, and then they mentioned how their patients had worse outcome after day 14. The rest of the differences, you can look into them. And the steroid dosing is what really was different. So I told you about the Midori protocol and how it's a total of 32 days, while the ARDS-NET did the same up till 14 days, and then the tapering was unique. So they tapered patients in 4 days if they reached the 21 days without being liberated from the vent. They tapered them over 2 days after the day 21 if they were liberated from the vent or if they had septic shock from a serious infection. So it was a very fast tapering compared to the tapering that happened in the Midori. And actually they found in that group of patients on Solumedrol that they had higher recurrence of the need for mechanical ventilation. And one of the explanations they gave is the fast tapering. So our protocol in Henry Ford is the Midori protocol. So we do the 32 days total with the same doses. We don't follow the NIH. So now, and this is the data. We have lots of meta-analysis that were dependent only on these studies. There was no big study that happened after the NIH trial, to my knowledge. So, and the last study was done in 2002. So you can imagine how much of advancement did we do on the vent, on fluid management, paralysis, proning, all the other parameters we use to have lung protective strategy in ARDS. So who is with, who is against steroids? That's a question. We know that from the NIH study, and from the Midori, maybe after the day 7 is when it's considered, not after day 14 though. And then there are many other questions to stratify patients into groups, because you cannot generalize steroids to everybody with ARDS. Some patients with ARDS are surgical versus medical. Some of them have underlying lung disease, and I hear the radiologist giving us a lecture about a retrospective study where he looked into the CAT scans of like 100 patients with ARDS. Significant number of them did have evidence of some interstitial lung disease on a CAT scan prior to coming to the hospital. So we cannot treat all patients the same. And then again, underlying liver disease, especially that we talk about procollagen 3 titers and how important it is and how predictive it is for mortality for ARDS. Many other comorbidities, including liver disease, have high titers of this marker of fibroproliferation. And in the era of ECMO, in the era of other strategies to be used in ARDS, where is the role of steroids? I don't have the answer, and I would just leave it to all of us to. Actually, I'm raising more questions than giving answers after this 15 minutes. So, thank you. My perfect scenario is a patient who has a normal echo 1 month ago on day 7, who's hemodynamically stable after a pneumonia, who has a negative precalcitonin, with a high titer of procollagen 3. I'm going to use steroids on him if he's stuck on the vent. And these are my references. Thanks.
Man, that's messed up. Y'all didn't clap for Syed. So my name is Jesse. I'm going to talk about neuromuscular blockade and acute respiratory distress. There was a meta-analysis that did come out, but it's largely dependent on this trial. So this is the trial that I'm going to focus on for my talk. This trial is also known as the ARDS trial. See at the bottom, the ARDS trial that was published almost 7 years ago. So the background of this trial, in patients undergoing mechanical ventilation secondary to ARDS, neuromuscular blocking agents may improve oxygenation and decrease ventilator-associated lung injury, but they may also cause muscle weakness. So this trial was brought about to look at the clinical outcomes after 2 days of neuromuscular blockade agents in patients with early severe ARDS. Just a little bit more background, just looking through some of the literature of neuromuscular blocking agents, it's pretty much been going on since people have been connected to a ventilator to help reduce patient ventilator asynchrony. They actually had a cohort analysis back in 1980 where they sent a survey to a lot of pulmonary critical care fellowships and asked them how many of these people were actually on neuromuscular blockade. And they had almost 60% of patients were on it, and they used a wide variety of neuromuscular blocking agents at that time. So, and there was no set protocol. Like only about 20% of the ICUs had a set protocol at that time of how they were actually titrating their neuromuscular blocking agents and how they were using it. So there was pretty much a no set protocol at the time, and people were using it very randomly. So over the time period, a lot of interest has been going on, especially with the known effects of muscle weakness. So this design, mostly in France, just like the PRON trial, it was a multi-center trial, 20 ICUs in France. It was double-blinded. The enrollment period was over 2 years, 2006 to 2008. 340 patients were presented to the ICU with severe ARDS in the previous 48 hours, 2 days, and they must have severe ARDS. And the severe ARDS at the time was defined as pretty much having a wedge pressure less than 18, and having no evidence of cardiac phenomena, having a PEEP of at least 5, and having a PF ratio of at least less than 150. There was either going to get a Nimbex or placebo, and the primary outcome was mortality before discharge or at 90 days. The inclusion criteria for this study was pretty much, like we said, a PF ratio less than 150, people greater than 5, a low tidal volume, so 6 to 8 mg per kg, bilateral pulmonary infiltrates consistent with pulmonary edema with absence of left atrial hypertension, so wedge less than 8, and if that's you was using a swan at the time. And if that was not available, then you can get an echocardiogram, and if there was no wedge, or if they had a history of ischemic heart disease, or if you had crackles on auscultation, which is pretty much everybody at the time. Exclusion criteria, of course, adults, if they couldn't get consent at the time, if they were pregnant, if they had severe chronic respiratory disease where they required long-term oxygen, or it was on home ventilation, there was obese, actual body weight greater than 1 mg per centimeter of height. If they had severe liver disease, on immunosuppression, bone marrow transplant, chemo-induced neutropenia, or if their expected duration, if they were just going to be intubated for a short amount of time period, they couldn't get consent, or other. And this was a randomization. They almost had over 1,300 patients. Almost 1,000 of these patients were excluded. They were left with over 340. And they had a pretty equal distribution of the patients, 170 to 162. One withdrew consent at the time. So they were pretty much left with almost equal distribution of patients into both arms, the placebo arm and the paralytic arm. The study treatment, they would use Nimbex. They used Nimbex or placebo on 30 milliliters vials. They did not use peripheral nerve stimulators, so they did not do a train of 4 to see if they had adequate response to the paralytic. They pretty much started these people on sedatives, so you have to get at least a Ramsey score of -6 to make sure that you're completely out. You'll have no glabellar reflexes at the time. And then you was given a pretty significant dose of Nimbex, a continual fusion of 37.5 milligrams per hour for 2 days. So a really, really high dose of Nimbex. And pretty much they had an open label. Pretty much if somebody has some kind of ventilator dysynchrony, you will still allow it, even in a placebo arm, to be able to use Nimbex. If you had a plateau pressure that was greater than 32 for at least 10 minutes, you can still use the Nimbex. And if you did see a response of less than 2 centimeters of water, then you can give a second injection of the Nimbex was allowed. This was a summary of the ventilator procedure to make sure that everybody was at least on the same kind of regimen. So they use volume control, 6 to 8 milliliters per kg. Plateau pressure had to be at least less than 32s. Oxygen goals were between 55 to 80. They used, if you look, that's the low PEEP table for PEEP recruitment mechanisms with FiO2. You're allowed to be a little bit more acidotic on this, and they had their own mechanisms to help you to, you can use vent mechanisms to decrease your acidosis, where you can increase your tidal volume if their pH was less than 7.2, or increase your tidal volume, or increase your respiratory rate if their pH was less than 7.2. Pretty much the same thing we do here. Just similar to baseline characteristics, it was pretty much equal along both of the cohorts both of the populations that we looked at. One of the biggest differences was actually the PAO to FiO2 ratio. Actually, in the Nimbex group, they tended to be a little bit more hypoxic, and it was actually significant. So they were a little bit more sicker at study initiation when you look at the population groups. And then just the outcome of the study, of course, there was a 90-day probability of survival mortality, and there was a significant difference between the Nimbex group and the placebo group. There was a 90-day mortality was 31% in the Nimbex group and 40% in the placebo group, and it was significant. When you look at our secondary outcomes between both groups, some of the stuff that, of course, that we looked at was ventilator-free days. So in the Nimbex group, you had a significant amount of ventilator-free days, which you would expect because you had a lower mortality in the Nimbex group. You also had, of course, which is kind of self-explanatory, a lot more days outside of the ICU, because, of course, if you have more ventilator days, you'll expect more days that you'll be outside of the ICU overall, and that was also significant. You also had a less incidence of barrel trauma. And barrel trauma was defined in the study as increased risk of, if you had pneumomediastinum, a pneumothorax, subcutaneous emphysema, or pneumatocyl. So if you had any of those three, you pretty much were thought to have barrel trauma. And if you could look at and also you had increased amounts in the placebo group compared to the paralytic group, NIMBX group. And then another one that I looked at, which I thought was, which of course brings into stuff that we're going to talk about later, it was the MRC. So that's the Medical Research Group score, which is a validated score that they looked at to look at weakness. So they looked at, and they did a physical exam on 3 extremities and pretty much said, okay, if your score was less than 40, you have some evidence of paralysis, some weakness in your extremities. If it was greater than 40, then you don't. So because of that, it was not significant. So between both groups, there was not a significant difference in any kind of paralytic-induced weakness. Which brings us to some criticisms and concerns from this trial. Are they blind? So, of course, if you're going to do a trial when you're looking at somebody, when you're comparing one group to the other group and using a paralytic, the obvious question comes into, can you truly blind a study where one is going to be paralyzed and the other one will not be? Because even though if you give somebody high sedations, if they have ventilator asynchrony, or if just somebody just looks like they're air hungry, air gasping, you can pretty much say that this person is not likely in a paralytic trial. So just obvious kind of just looking at the patient, you can probably think that this person may not be in, they may be in the placebo arm. So there could be some bias from just being not able to truly blind a study where you are using paralytics. Can they move? So since the effectiveness, since you were not able to do a train of 4, how do you know these people were actually really paralyzed? You know, when I looked at, there was a correspondence when they talked to the author of the study, and he talked back saying that we gave such a high dose of paralytics that it's pretty much going to be impossible for them not to be paralyzed. But without a train of 4, you still have this question in the back of your head where you're saying that, can you truly say that these people were truly paralyzed as opposed to the other group, because you never really truly assessed like a train of 4 in there. So how do you know? There was no certainty. Of course, they didn't do the train of 4 because it would have led to some kind of bias. Again, going back to the fact of, are they blind? Because if this group had a train of 4, then you would know that they're not paralyzed. So it still goes back to the reason why they didn't do that was to try to help this study be more blinded. But it does bring into question some of the concerns of the trial. You're not supposed to be here. Why is that? Because when they actually looked at previous studies, they calculated that they should have been at least a 50% mortality in this study. The mortality in the placebo arm was only 40%. So then they pretty much came to the conclusion that they did not have enough people in the study to be able to. The power was not strong enough in the study. So they actually calculated that they needed at least twice that number, at least 840 patients to be able to truly power this study. So with that, given, the study was underpowered. So that was also a very big concern when you start looking at some of the papers that was went there. But overall, it did show a good outcome. Early administration of neuromuscular blockade was in 2 days, and it did improve your 90-day survival and your time off of a ventilator, and it did not increase muscle weakness. The other thing that was, also mentioned is that the GlaxoSmith provided the drugs to the study, and then, of course, they are the marketers of NIMBX, so there was also a part of that was actually of concern in the study, but it wasn't as big as, of course, this not truly being a truly blinded study. Oh, thank you.
Thanks. Does anyone who doesn't have an audience response that came a little bit late? Anyone else? I have a few of them. No, they're right there. So there are some behind. Don't take them with you. All right. All right, so I'll be talking about inhaled vasodilators. Sorry, I'm not wearing a suit. I did not know we were doing that today. But so, in terms of the main medications I'm talking about, so nitric oxide and prostacyclins. These are two therapies that have some evidence out there that are circulating for ARDS. So a little bit about the mechanism of action, just very briefly. Nitric oxide works on the activation of the guanylate cyclase receptor here, which increases cyclic GMP, and from there you've got move forward. You've got inhibition of calcium release from the cytoplasmic reticulum. You also got decrease in sensitivity of myosin, and this will all cause a vasodilatory effect in the concept in the pulmonary artery, and that's how it causes vasodilation. But I have a series of questions that we're going to go through, probably 4 of them. So let's just start with the first one. So you have a 34-year-old male, no past medical history, admitted to the ICU ARDS after a significant motor vehicle accident. He's currently on volume control with a total volume 300. Respiratory rate is 26, FiO2 200% with people with 20. Plateau is 35. You got a pH of 7.15. The CO2 is 65. PaO2 is 45. He's paralyzed, not candidate to prone positioning due to multiple rib fractures. I'm not sure if that's actually a contraindication, but I would not want to do that. Due to significant respiratory acidosis, you decide not to do APRV, and you consider nitric oxide. So the question is, if you want to start nitric oxide, what do you expect will happen? So you can go ahead and start answering. So A, worsening VQ mismatch. B, improved mortality. C is increased PF ratio. D is increased mean pulmonary artery pressure. And last one is E, which is decreased time on the ventilator. There should be more up there. There's 26 of these ARDS response. So you can answer no one would know what you answered. So that's the point. So all right. So. Okay, 17. So let's go move forward. So the answer is C. So it improves the PF ratio, and that's really why we use nitric oxide. Now, so worsening VQ mismatch. So we talked about this before during our last session about does nitric oxide increase VQ mismatch, and the concept is you would think that it causes vasodilator pulmonary arteries or capillaries there, especially in the alveoli that are not really well ventilated or aerated, I should say, and oxygenated. So you do have worsening the VQ mismatch. But if you look at normal physiology, obviously you've got normal amount of shunting that you see at all times. If you look at here in B, what happens is, let's say if you have a situation where you have a pneumonia, you've got some bad alveoli here, so you've got hypoxic vasoconstriction, and that's just to minimize the VQ mismatch that you have. Now, if you add nitric oxide, inhaled nitric oxide, or inhaled vasodilator therapy, I should say, this will favor the normal alveoli. So you'll have selective vasodilator effect in the normal, in the capillary bed of the normal alveoli, and not where you got alveolar damage in areas where you have significant ARDS, which is why you have improvement in VQ mismatch actually, and improvement in the PaO2 while you're on inhaled therapy. Now, if you look at here C, this is what happens when you give intravenous vasodilator therapy. You've got actually generalized vasodilatory effect, which actually worsens VQ mismatch and causes hypoxia. And then in E here, what you have is sometimes there's some dysregulations in the pulmonary vascular tone, you can have generalized vasodilatory effect. And also maybe in prolonged inhaled nitric oxide use, what will happen is that you'll have again, generalized vasodilatory effect, which can worsen VQ mismatch, which is why in prolonged use of inhaled therapy, you can actually have worsening of your oxygenation with time. So this is a very early study. This is the first human study on using vasodilator therapy, published back in '93 in New England. So what they found is that they used both inhaled nitric oxide and then they used IV prostacyclin, and what they found is that the P to F ratio has improved significantly. This is baseline, and this is 2 different doses, so it has improved, and that was statistically significant. And when they used intravenous therapy, there is a drop in the P to F ratio. So just remember that actually inhaled therapy actually improves VQ mismatch and not worsens it. And this is, they also made calculations looking at the amount of shunt that you have, and again, you have decreased shunting on inhaled therapy, and you actually have increased shunting with intravenous therapy, and that kind of goes back into how the mechanism of actions of the medications. All right, next question. Which patient responds least to inhaled vasodilator therapy? You got aspiration pneumonia, trauma, pneumonia, sepsis, and pancreatitis. Sorry, pneumonia, aspiration pneumonia are different entities. All right, so last time I had 17 responses, so I'm hoping to get closer to that number. All right, 19, 20. So correct answer is D. So a lot of answers everywhere. So actually in sepsis, you've got the least response to vasodilator therapy. And this is based on a few studies out there. This is the most recent one, that's why I added it, but this has been actually proven in multiple studies. This was published in 2017, August, so just not too long ago. It showed that patients with, first of all, patients with a high P to F ratio to start off with have the best improvement in terms of their P to F ratio, and you can see that here. So if you start off very high with a good P to F ratio, you've got the highest increase. Having said that, though, I mean, looking at it, I think it's more of a percent change, and actually the percent change might actually be the same. But one thing is that if you have better oxygen to begin with, you get a better response. The other thing as well, look at the study, is looking at sepsis. So they bunched up all the patients in sepsis compared to non-sepsis. And the patients with sepsis did have an improvement in their oxygenation, but not as significant as those without that did not have sepsis. And looking at the exact breakdown, actually trauma patients have the best response. Again, aspiration second, but pneumonia and sepsis, which is what we really use, what we usually deal with, actually have the least response to inhaled vasodilator therapy. So, all right, next question. The use of inhaled nitric oxide is associated with which one of the following complications? So you've got renal failure, bleeding, pneumothorax, LV dysfunction, and nitric oxide toxicity. Okay, so that's close to 20, so 21. So correct answer, again, answers all over the place, so, but the correct answer is renal failure. And usually the vasodilator therapy has very minimal side effects. If you look at the outcomes, and this is from a Cochrane meta-analysis that was published last year in 2016, looking at nitric oxide in ARDS. So he found that the mortality has no difference in mortality, no difference in 28-day mortality. There's an improvement in the P to F ratio, as we already talked about. A mean difference was 15, and it was statistically significant. And also, there's no difference in vent-free days. And then they looked at several complications, and the one I want to comment on is renal failure. They found that there is worsening renal failure in that study group. So this is what I'm highlighting. Having said that, what they actually did then is that they removed one of the studies which they think that is a high risk of bias, and they did the analysis again on just the 3 studies that were left, and they found that no, maybe there might not be that much of a difference. But there's some studies out there that have kind of talk about renal failure with inhaled nitric oxide. But otherwise, it's not really, not a lot of complications. All right, question 4. I know I'm moving too fast, but we're a little bit out of time. So 50-year-old female, past mild history of diabetes, hypertension, comes in with pneumonia ARDS on the vent based on ARDS net protocol. Due to refractory hypoxia, she was started on nitric oxide. 12 hours later, the patient became tachycardic hypoxic with evidence of central and peripheral cyanosis. Her PaO2, though, was 80. 5 hours later, she still appears to have seizure-like activity. What is the next step in management? So you've got needle decompression, and you can start answering. Needle decompression, NICU consult for cerebral edema. You want to do an echo, You want to check nitrogen dioxide level concentrations, or I want to give methylene blue. What? So what did you say? Is that your answer?
Does it exist? No.
Oh, that's actually a good question. It does exist, but it's a good question. I'll talk about it in a second.
You can't say it's not the right answer.
All right, so let's move forward. So the answer is methylene blue. So, all right, most people know this, and that's actually in some protocols they always ask you to check methylene blue like 6 hours or so, and very often after the use or the initiation of nitric oxide, and it's in most protocols as well. Again, going back at the Cochrane review that we just talked about in 2016, they look at different complications. Really, the incidence of methylene or methylglobinemia is really, really low. You can see that we're looking at, I think these are 13 trials or so, like very few actually even report that complication occurring, and when they do report it, there's no difference between the group. So this is usually found in people with methylene reductase and the enzyme deficiency, which is acquired, and it can be congenital, which is why they actually see it, and they can use nitric oxide in pediatric population. You might see it in them more than adults. So even though they talk about it might be in some protocols, it's actually not that prevalent. And otherwise, as I mentioned, renal failure being there, the risks are really low. So I want to talk about the last one, so inhaled prostaglandins. So there's actually a lot of interest on this right now. The reason why is because it's much cheaper than nitric oxide. So I think it costs like $300 a day compared to $3,000 a day using inhaled nitric oxide. This is a study from CHEST. There's a meta-analysis, and what they found is that from 16 studies, and these are all kind of observational studies, and I think we only had 2 randomized controlled trials. They found that, again, PDUF ratio has improved significantly while on inhaled prostaglandins. And they had, I think the 2 medications used epoprostenol and another medication as well. The PaO2 has also increased significantly, and the mean pulmonary artery pressure has dropped. They haven't looked at, most studies, these are very early studies, so they actually look at mortality as their endpoint. They just look at these specific numbers, so look at oxygenation and PA pressures. So there's also a Cochrane review back in 2010 that they did, which included only 1 pediatric study. So they said it's not recommended at that time. Since then, there was only 1 randomized controlled trial actually published in Pakistan. So looking at inhaled epoprostenol. So really there's no evidence out there. I know we use it, but there is documented improved oxygenation, but that's basically it. But there's more studies out there, I'm sure. Again, the interest is because of costs. So in terms of ARDS, so I know Alaa talked about this earlier. So there's in May they brought up this new publication about guidelines. ATS came up with guidelines. Looked everywhere else at all societies. No real guidelines on ARDS. And look at the questions that they tried to answer. They had 6 questions they really start off with and tried to answer. None of them talk about nitric oxide. And I agree with you that I think it's because there's weak evidence on some of the aspects. And it's not just vent management, because I know you said vent, but they do include proning here, so which is not really vent management. So I think it's just weak evidence, which is why they don't even talk about nitric oxide or steroids or the other modalities. So with that said, in my opinion, I think nitric oxide, there's weak evidence to start it. It's very expensive medication, and I think this just reinforces the idea that oxygenation is only a number, and we've had multiple studies that shows looking at oxygenation is not maybe the endpoint that we should be looking at in terms of improvement in outcomes and so on and so forth. So with that, I would just open up for a little bit of discussion for a few minutes. So would you offer these therapies that we talked about to your patients? So I'll just put on there on the floor, and if you have any questions, and the questions can be directed to all of us, not just me.
One of the comments I would have, both of you asked questions about the guidelines, and when you pick questions for guidelines, there are several criteria that you look for. One is you want it to be controversial, because if it's not controversial, there's no point writing about it. You want to have an adequate amount of evidence so that you can properly answer the question, ideally But the third thing is that you're always limited by costs and personnel into how many questions you address. So they may well have been in a situation where they could answer only a certain number of questions, and so they picked the ones that they thought were the most important. And it may simply be that the ones that you guys were asking didn't make the cut.
Yes.
Also, I think some of the background activity that's occurred in the last couple of decades is glucose control. If you look at trials prior to glucose control, you saw a greater effect of paralytics in terms of myopathy. In addition, we used Avalon, which is a longer-acting paralytic. And when we used that with steroids, we used to see prolonged myopathy syndromes. But in 2001, Rick Vandenberg came up with the glucose control protocol. And if you look in our study, myopathy was 0. So when you combine glucose control in addition with paralytics, you actually help glucose control actually improves the myopathy syndrome. So remember, insulin is a growth hormone. So the use of insulin actually improves muscle activity as well as muscle regeneration.
Yes, Doctor.
I have a question, one for Jesse and one for Razvi. So, sort of to piggyback on Dr. Rivers' comment about paralytics, did the authors of your study explain why they used a dose that was so incredibly high? I mean, it's like 10 times what the manufacturer recommends in terms of...
They didn't explain it more in the trial. It was more in the correspondence because more than one person actually emailed them talking about that. What their rationale was, just because they weren't going to do a train of 4, their goal was to try to eliminate any kind of reason that this person would not be paralyzed. So that's why they use such a high dose, because since you can't do a train of 4, you can't titrate it up and try to see, okay, at what dose is this person completely paralyzed? I was like, let's just go for this such high dose just to make sure that they're completely paralyzed. So that's why they...
You're exactly right, because if you used a train of 4, you would get rid of any semblance of blinding.
Any kind of
blinding. Which in which arm, and so they couldn't do that, so they wanted to make sure they were adequately paralyzed.
Yeah, unless you use like dummy neurostimulators. But I guess the other question then is, did they see any adverse effects of such high dose paralytics,
So they didn't, and one of their rationale is that before when people did other kind of when people evaluated myopathy with paralytics, they use a lot of the steroid paralytics. This is a non-steroidal paralytic, so they had less effects of myopathy than some of the previous ones. So when they looked at their 90-day secondary endpoints, there was, and looking at the modified research scale that they used, they did not see any incidence that was significant of myopathy. And even when they compared it to people who was on steroids, so even with the addition of steroids, there was no higher incidence of myopathy.
And the pedal network decided to use the same dose because they didn't want there to be confusion between the two studies that had what might be due to dosing of paralytics. So patients that you were seeing upstairs that are being randomized to paralysis are getting the same dose of paralytics.
So, Dr. Razvi, you talked about proning. What do you know what our numbers in our medical ICU are in terms of what our protocol looks like, or how many patients are prone, and how closely we adhere?
I haven't looked at it, but honestly, my experience, I think I used my 3 years there. That's it. Who ended up on ECMO, but I don't really know the numbers.
And the reason I ask is because we talked about the fact that having a team that really sort of thinks about all of the factors that are important when you prone a patient, like the endotracheal tube and abdominal pressure and all of those things, I think probably go under-recognized if we don't do it too frequently. And I'm curious to see what our numbers are proning versus ECMO.
The centers that had the literature from the ICUs, they had a lot of experience. They even have published stuff like pregnant women, they were prone. So they have a whole checklist and videos, so they go through a checklist and everything. So they have a lot of, and they just use, in the study they use regular beds, so they wasn't even the proning bed. So they have a lot of experience doing that stuff. So
I think this speaks to one of the things I wanted them to talk about, which is hard to talk about, which is coming up with a standard protocol. We're never going to prone safely if we don't prone regularly. And we're never going to prone regularly if we all don't agree that here's the criteria and we're going to prone. I'm not arguing that the data strongly supports or doesn't support proning. It's just that if we think we want to do it, we all have to do it, because otherwise our nurses will never feel comfortable proning a patient.
When I was at Mayo, this actually came up and we introduced a refractory hyperxemia protocol and started proning more. The VV ECMO numbers went down, so the ECMO team was very unhappy. And we actually had to